Okay, let's get into this. We're doing a deep dive today on a really complex topic in veterinary medicine.
We are the pharmacological management of mast cell tumors, or MCTs, in dogs and cats.
And if you, our listener, have ever seen the medication list for one of these patients, I mean, it's an entire pharmacy shelf.
It really is.
So our mission today, looking through all this clinical data, is to figure out why. Because this is so much more than just a cancer treatment. It's about this whole stack of medications you need just to contain the biological crisis these tumors create.
That phrase, biological crisis, is perfect. It's the key. Mast cell tumors are unique because the cells themselves are essentially, well, they're chemical time bombs.
Right.
If you irritate them, manipulate them, or sometimes for no reason at all, they degranulate.
And when that happens, it's not one thing they release. It's a whole cocktail of chemicals.
Precisely. A powerful mix of mediators. You've got histamine, heparin, cytokines, all these other vasoactive amines just flooding the system.
A flood that has consequences way, way beyond the tumor itself.
Oh, absolutely. Locally, you might see what's called the Darrier sign. So redness, swelling, maybe some bruising. But it's the systemic effects that are truly terrifying.
And what does that look like?
We're talking life-threatening GI, bleeding from massive hyperacidity, blood clotting problems, a sudden drop in blood pressure, even acute respiratory distress. So the entire management strategy has to focus on stopping that from happening first.
If you can't stabilize the patient's internal chemistry, you can't even begin to treat the cancer.
You've got it.
Okay, so that sets the stage perfectly. If histamine is a primary villain here, the first line of defense has to be blocking it. Let's talk about the H1 antagonists.
Right, the frontline histamine blockers.
And clinicians use these when signs are already there, but also, and this is critical prophylactically, right, before they even touch the tumor for, say, a biopsy.
Yes, and the drug everyone knows is diphenhydramine, a classic first-generation H1 blocker. It blocks histamine and has some useful anticholinergic properties. But there is a massive caveat in veterinary medicine.
And that is its bioavailability.
Its oral bioavailability in dogs is.
Yeah.
It's just shockingly poor.
The sources put it at something like 2 to 8% absorption, is that right?
Exactly. Which means if you're relying on an oral dose right before a procedure, you're taking a huge risk that it won't be effective in time.
So the injectable route is really the only reliable way to go in an acute setting.
It's strongly preferred, yeah. SC, IM, or IV when you're worried about degranulation happening right then and there.
What other warnings come with diphenhydramine?
Well, while it usually causes sedation, you can get the opposite. Paradoxical excitability. We see it sometimes in cats and even in some large breed dogs. They get agitated.
So the advice is to start low and go slow.
Always. And there are some reports in humans of tissue damage from subcutaneous injections, so that's something to be mindful of.
Okay, so that brings up an interesting point. Not all mast cells are the same, especially across species. Let's talk about the special case of cyproheptadine.
Ah, yes. Cyproheptadine is fascinating because it's not just an H1 blocker. It has this dual role.
It's also anti-serotonergic.
Exactly. It blocks serotonin. And that's vital for cats because some research suggests serotonin, not histamine, might be the main chemical released from feline mast cells.
So for a cat, especially one with a GI mast cell tumor, just blocking histamine might not cut it.
It might not be enough. No, you need to block the serotonin too. And as a great side benefit, it's also a pretty reliable appetite stimulant.
A definite 2-for-1. And just to round out the section, let's briefly mention loratadine and chlorpheniramine.
Sure. Loratadine is a second gen, so it's non-sedating. The in vitro studies looked really promising. It suppressed histamine release in canine mast cell lines, but we're still waiting on more definitive in vivo data.
And chlorpheniramine.
Another first gen. It's useful for dampening the effects during surgery, and it's good for the severe itching, the pruritus that can happen. The only real catch is that cats tend to hate the taste, so getting it into them can be a challenge.
Okay, so we've managed the immediate chemical storm. But that constant low-level release of histamine is doing serious collateral damage to the gut.
That's the next battlefield.
Right. We need to pivot to managing hyperacidity and preventing those catastrophic ulcers. So let's talk H2 antagonists and PPIs.
This is a crucial shift. That histamine from the tumor gets into the bloodstream, travels to the stomach, and it hits the H2 receptors on the parietal cells.
The stomach's acid factories?
Exactly. And it tells them to go into overdrive.
And the classic drug we see here is cimetidine. How does it work?
It competitively inhibits histamine at those H2 receptors, so it dials back the acid production. The problem is, It's a bit of a messy drug.
Messy in terms of interactions.
Very. It affects how the liver metabolizes a whole host of other drugs. So if your patient's on chemotherapy, certain antibiotics, heart meds, you have to be incredibly careful. Plus, its absorption is significantly reduced by food.
Sounds like a bit of a minefield, which I guess is why many clinicians prefer famotidine.
Yeah, famotidine is much cleaner, it lasts longer, and has far fewer drug interactions. It's generally a safer bet.
But it has its own limitation, especially for long-term use.
It does. After about 2 weeks of continuous use, we often see its effectiveness on stomach pH start to decrease. The body just adapts.
A phenomenon called tachyphylaxis.
Right, and that means for true long-term control, you usually need to step up to the proton pump inhibitors.
We should also quickly mention ranitidine.
We should. It was potent, safer than cimetidine for the liver. But here's the critical nugget for everyone to remember. Ranitidine for humans was pulled from the market in the US, Europe, and elsewhere because of contamination issues, so it's just not readily available anymore.
So if the H2 blockers are losing the fight, we bring in the heavy artillery, the PPIs, like omeprazole.
And omeprazole is a fundamental step up. It doesn't just block a receptor, it binds irreversibly to the proton pump itself.
The actual acid pump.
Yeah, it shuts down the factory machinery directly. You get over 90% inhibition of acid transport.
That sounds incredibly powerful, but there's a delay, isn't there?
There is, and it's a critical point.
Yeah.
It takes about 3 to 5 days for omeprazole to reach its full effect.
So for a patient that comes in with active GI bleeding, you can't just rely on omeprazole to get you out of trouble on day one.
Absolutely not. In those high-risk cases, you'd use an H2 blocker with the omeprazole for those first few days, just to bridge the gap and get some immediate acid suppression.
And a quick note on formulation, you can't crush these, right?
Never. They have an enteric coating to protect the drug from stomach acid. If you break that coating, the drug gets destroyed before it can be absorbed.
Okay, so we've blocked the histamine and shut down the acid. But what if the damage is already done? What if there's an active ulcer?
This is where sucralfate becomes essential. It's not an antacid. It's more like a bandage.
A bandage.
It reacts with the stomach acid to form this thick, protective paste. And that paste binds directly to the ulcer, coating it and protecting it so it can heal.
That makes sense. But if it's forming a paste that coats everything, it must interfere with other drugs.
You've hit on the crucial warning.
Mm-hmm.
It does. It can bind to other medications and prevent their absorption. You have to give sucralfate at least 2 hours apart from everything else.
Timing is everything.
Everything.
We should also touch on misoprostol.
Misoprostol is a prostaglandin analog. It helps enhance the mucosal barrier and can inhibit acid secretion. It's used more for preventing ulcers, especially NSAID-induced ones, rather than treating an active MCT-related ulcer.
And it comes with a massive warning label.
A non-negotiable one. Misoprostol is a potent abortifacient. It's absolutely contraindicated in pregnant animals, and women who are pregnant or trying to conceive should not handle the drug at all. The risk is that serious.
It really underscores how careful you have to be. Okay, let's shift gears for our final section. We've been managing symptoms, but now let's talk about agents that target the inflammation and the tumor itself, starting with the workhorse, glucocorticoids.
Right, steroids like prednisone and prednisolone, they're essential because they fight the tumor on multiple fronts. They reduce the swelling, but they also directly inhibit the mast cell proliferation and can even induce cell death.
So they provide really important short-term benefits.
They do, weeks to months. But it's always a trade-off. Long-term use comes with all the classic steroid side effects, the drinking, the urinating, panting, immunosuppression.
So you're constantly balancing the benefit against the quality of life.
Constantly.
Yeah.
And we have to make a key species distinction here between prednisone and prednisolone.
Right. Prednisone needs to be activated by the liver.
And cats are not very good at that. So for cats, and for any dog with significant liver disease, you should always use prednisolone to make sure they're getting the active drug.
And briefly, there's also triamcinolone.
That's usually reserved for injecting directly into small, isolated lesions, maybe if surgery isn't an option. The response rate is decent, around 67%, but it's not a solution for larger or metastatic disease.
Okay, and this is where our deep dive gets really interesting, because there's a novel agent, Tigelinol tiglet, that basically ties every single drug class we've just discussed into one mandatory high-stakes protocol.
It really does. Tigelinol tiglet is a small molecule agent for non-metastatic MCTs in dogs. And it works by causing a very rapid and aggressive destruction of the tumor.
How does it do that?
3 ways. It causes direct cell death, It provokes a massive inflammatory response that chokes off the tumor's blood supply, and it makes the blood vessels leaky.
That sounds incredibly effective, but also incredibly provocative to any remaining mast cells.
That's exactly it. The risk of a massive, fatal degranulation event after the injection is severe.
Which is why the multi-drug stack is mandatory.
It's not optional. Concurrent use with a corticosteroid, an H1 antagonist, and an H2 antagonist is required. The sources are clear. Failure to do this can result in death.
That is it's a dramatic underscore of the stakes. And the timing is really specific, isn't it?
It's technically demanding. The steroid, prednisone or prednisolone, has to start 2 full days before the injection.
2 days before.
Yes, and it continues for 7 days after. The H1 and H2 blockers start on the day of the injection and also continue for 7 days.
So if a vet skips that 2-day steroid preload, they are putting that patient at extreme risk.
Extreme, potentially fatal risk, yes. And we haven't even mentioned the injection technique itself. It has to go directly into the tumor, never around it, because it causes severe tissue necrosis. It creates a large open wound as the tumor dies and slews away.
Wow. We have covered a tremendous amount of ground. I think if you came into this thinking MCT management was just about surgery, you now have a much clearer picture.
For sure. We've gone from blocking the initial histamine storm to protecting the gut with layers of medication, and finally to directly targeting the tumor with agents that require their own complex safety protocols.
The big takeaway for you, the listener, is just how nuanced this all is. The ultimate goal isn't just about shrinking the tumor. It's about successfully managing the lethal side effects of the tumor itself, so the patient can live long enough to benefit from the cancer therapy.
And that leads us to a final thought for you to mull over. We mentioned that a drug like famotidine can lose its effectiveness over time, that tachyphylaxis. What does that tell us about the broader challenge of chronic symptom management in oncology? And what does it say about the ongoing need to find new ways to keep these supportive therapies effective, not just for 2 weeks, but for the entire life of the patient? It really reminds you that the race in drug development is never truly over.